Hey there, tribe. Good day to you. I'm
Hey guys.
that you've joined us. This is Gary. He has been in nursing for 32 years, and he's been primarily in the ER, but has a passion for cardiac and education. So thank you so much for joining us today, Gary.
Thank you for having me.
Yeah,
Welcome, everybody.
I'm really excited to discuss the basics of EKG interpretation and learn a little bit more about where these rhythms are initiating and how all of that works. I would love to discuss that. And I know there's been a great interest for the concept because so many people are scared of it. So why don't you introduce yourself? Anything you'd like to add to my introduction?
Sure. Well, thank you. Well, like Chelsea said, I've been a nurse for 32 years, specializing in ER, emergency medicine. The last 10 years, I was a float nurse, so I would cross-train because I have experience in ICU, every floor. And the thing was, I'd be working 2 hours in an emergency room taking care of a 1-year-old or a 3-week-old baby. Next thing you know, I said, Gary, want you in ICU? You're short here. So next time you're taking your 100-year-old person on 10 different drips. So you really it was really challenging. But as all nurses, that's why we got into it. It's a challenging field, and that's why we enjoy it. And I know EKGs can be challenging. I got into this because I was a cardiac nurse for 7 years, and I knew all the EKG rhythms down, pat, ACLS codes, all that stuff. 12 leads really bothered me. And so then I took a 6-month hiatus. I focused on 12 leads, studied, bought every DVD you could think of. The more I studied, the more confused I got. Then I started working with some cardiologists. They really helped it a lot. 12 leads are my specialty. And then when I started showing people 12 leads, they forgot the regular rhythms. So I have two things, 12 leads and regular EKGs. And that's what I did, the EKG Basics. And it's a lot of animations. It's seeing it, hearing it, doing it. That's the best way you learn. That's my opinion. Some people like lectures. I'd fall asleep during lectures. That's just the way I am, especially with a 4-hour lecture. And some of these people are so knowledgeable, but bringing the message across, that's where they lack. You can't have a EP doctor explain it to a bunch of nurses because he's going way up here and you're still down here. I mean, there are some good ones, but sometimes they go overboard and we're scared to ask questions. So what I told Chelsea, if you have any questions, if you can save them for the end, I'll just do a brief presentation. If you guys like it, I can always talk to Chelsea. I can always come back and do more in-depth ones, a little more time, because we're on limited time here, but I will have them. I got some great animations showing some things, and we'll get started anytime.
Yeah.
Any questions for me? Hold on to the end, but I think I think you'll enjoy it. I've had a lot of good reviews on this. I do a lot of teaching for hospitals and everything, so anytime you're ready.
Awesome. So guys, go ahead and get your questions in. Actually, as you think of them, put them in the chat. And at the very end, we'll go through the questions that you've asked at the very end. So we're going to do this one a little bit different. We're going to discuss initially the process of looking at an EKG because so many people are so put off and scared of how am I going to know that that rhythm is too fast, too slow, safe, unsafe. So we're going to touch on the basics of that. And then Gary put together a little presentation for us, which I think will be super informative and knowledgeable. He's super knowledgeable in the area, so I'm excited. Interpreting EKGs was never my specialty. I would definitely not call myself an expert in any way. In the PICU, we would print a strip every day and we would look at it and compare it to the previous strips of the patient's admission. But in terms of having a whole lot of knowledge and comfort, I felt like I could just say, that doesn't look right. What would you say, Gary, in teaching any of us the basics of figuring out that this is safe, unsafe, too fast, too slow? What do you like to start with, the very basics?
I like to start out with, as nurses, there's so many things we do. I've probably read 5,000 to 10,000 12-lead EKGs. I have them, before the HIPAA thing, doctors would send me them. I'm graphically redoing them. You don't have to be an expert in EKG interpretation. You just know when to call one, and recognize the changes. And more important than anything is, how's the patient? You could have someone go to a sinus rhythm, and the biggest thing is, and I'll talk about that, also they go to a junctional rhythm, but their heart rate's still 60.
Mhm.
You have to do a visual check on them because they can go to PEA. I don't know if you guys are familiar with pulses electrical activity. Your heart's just like that. Like I say, someone's life can change in a heartbeat. So when you see a change, and like Chelsea said, you have a normal sinus, look at their rhythm before what changed. If you're not sure, ask other people. We are so, everybody's intimidated by EKGs. When I work with cardiologists, because I'm so, I've done this, I would ask, one of the doctors, like in the emergency room, hey, what do you think it is? Are you testing me? No, I'm not testing you. I want your opinion. We're a team. We work together.
Mhm.
I have no problem going up to somebody, hey, is Lasix, Levofed and all this stuff compatible? I mean, I check with pharmacy, and when I know they are, I say, hey, look, guys, this is all compatible. So we teach ourselves, and work together as a team. Don't be intimidated by this, and I will show you. It's just recognizing EKGs, and the best thing to do is practice. At your hospital, you have access to everybody's EKG. Look at them. That's the only way you'll get good at it. Everybody has a 12 lead in their chart. When you start looking at 12 leads, you can start seeing things. Look at the rhythms, oh, okay, that's that. And what can I just start out right now? Why does every rhythm look different? Because look at me and Chelsea. We're both humans, but we got two different faces. Nobody has the exact face. Nobody has the exact EKG. So normal sinus may be upright on somebody's and maybe down on the other one. Depends on their body size. It could be someone that's 400 pounds. Just think of the resistance those EKG leads, the placement of the EKG leads, but it all follows the same criteria. It should have a P wave. It should have a QRS. It should have a T wave. The rate should be regular. It could be fast or slow, and I'll break that down for you guys because there's a systematic approach, but you guys will develop your own, and I'll show you how you guys do that. But again, remember, no EKG is exactly alike because when you think about it, how an EKG has been around for 100 years, we're still attaching external cables. And think of all the interference that gets there. We don't have a magic wand that can say, oh, that's what it is. It's this rhythm. And when you think about it, there's standards for CPR, there's standards for stroke, but there are no standards for EKG interpretation. And it's very challenging. So I'm going to give you guys some examples and help you take the fear out of what you're looking at and give you a good in-depth explanation.
So speaking of external wires and such, someone posed a really great question about Apple Watches and their utilization and helpfulness versus unhelpfulness in our current medical realm. What do you think on that?
I think it's good. It gives you just one lead. It gives you lead 2.
Uh-huh.
And when you think about it, you can take an EKG and hold it on your fingers, but it's measuring, and I don't know exactly, I met the guy that designed that at a conference and how you put your 2 fingers here so it's going through your body. I don't know how the Apple Watch gets the rhythm on one side of your wrist, the other side, but it's great technology. But I know a lot of doctors, people get hooked on that. Okay, my heart rate's 84. Oh, now it's 76. I've had people call me, hey, I got it, call me and say, Gary, my heart rate's 74. And I said, okay, that's good. 60 to 100, you're all right. Does it look regular? Yeah. That changes. I think they're great for someone that has atrial fib, a history atrial fib, which, by the way, is the most common dysrhythmia in the world. And with atrial fib, if you can recognize it, then you can say, because people go in and out of it. And with atrial fib, again, you have about a 500% chance of having a major stroke with atrial fib. So the most common rhythm in the world is normal sinus. The most common dysrhythmia in the world is atrial fib. Those are the ones you're going to see the most. Yeah, I think that's good at all technology, but what we need is actually something to make it where I can just scan something over you and have a perfect EKG, because the EKG is the most important diagnostic test, and that's at the center of the pathway for treatment on a patient. If you come in chest pain and I look and I don't see any EKGs and I do troponins, because EKG is the first part, but then you do troponins irregular. Okay, we're going to observe you. If your troponins are positive, you have ST elevation, cath lab right away. Get you in ICU or cath lab or whatever you have to do. So the EKG is very important. Now, with all COVID patients, being cardiac monitored, and studies have shown that even 6 months after COVID recovery,
Yeah.
people are having myocarditis.
Mm-hmm.
And myocarditis, I know a lot of people. I worked in a COVID unit. We opened our first COVID unit, and we'd see people having dysrhythmias, like first degree. A minor first degree would be new for them. Well, we knew it was inflammation changing it. But then a lot of my friends caught it, and the one was athletic. She was very a runner and all that stuff, and no medical history, 45 years old, and now she's basically in a wheelchair. She can't run. I mean, she's a doctor. She still practices, but it's hard. So with COVID, we're going to have more and more people on telly later on, even once we get cured on this, because a lot of people have heart problems after COVID. It attacks the heart.
Yeah.
Yeah, this is a weird times, but now cardiac more important than everything. We have to get better at interpreting EKGs. And again, you don't have to be an expert. You just got to recognize changes and when to call one.
Yeah, I always used a step-by-step interpretation guide for myself when I was on the unit. And that's what I would teach my newer nurses that I was training. So I look forward to hearing your EKG interpretation steps that you're going to teach us. I think we may as well just get into your presentation and see what you have to say.
Sure.
All right, so let's do this. And I'm going to take myself away. And Gary, you've got the floor.
Okay. Everybody see it? I think so. Okay. Understanding EKGs and interpreting EKGs. This is a company I developed, EKG Concepts, 11 years ago, and I've developed new products. This course is protected by U.S. copyright, but I told Chelsea she could record this because I have a lot of animations which I can't give out because I pay for. But I'd like to say, here's developer this. Okay, here's your heart. It's the main engine of the body. When you think about it, if I have a stroke, that affects my brain. There's a good chance I could still survive. I may be, disabled, but I still could survive. If my kidneys fail, I could get a kidney transplant. I could go on dialysis. My lungs fail. I can still live with one lung, but my heart supplies everything. It supplies blood to everything. So if that fails, it doesn't matter. It's shut down. A little bit of anatomy and physiology. I'm just going to touch on this. This is the aorta. There's the actual picture of an aorta. See how thick it is? Because the left ventricle is pumping blood throughout the whole system. You have 4 main arteries, or actually 3. Your right coronary artery, which supplies blood to your inferior wall. Your left main, which breaks off into your circumflex, which affects the backside of the heart. And your left descending artery. Okay, 4. Sorry about that. And on the backside, you have your posterior ascent. So here's the thing. Once you understand this, see how the blood's pumping on the left and anterior? When it's pumping out, that's systole. It's pumping blood throughout your whole body. During diastole, when it's resting, the blood just falls and feeds itself. It feeds the coronary arteries blood, oxygenated blood on the front and the back. So this used to drive me crazy. Okay, why do you have blockage in your heart? And I don't have blockage in my arm or my hand or my leg. Why? Because this is all per gravity. During diastole, the blood just falls down in here in these coronary arteries, so you can see how if there's any blockage, it would be blocked. And again, it would cause heart's a muscle, so you need oxygen. So 3 stages of an MI or myocardial infarction. You have ischemia. You have insufficient amount of oxygen by that section of the blood. And here's a coronary artery. It's partially blocked. And you don't have any dead muscle tissue yet, but it's just lack of oxygen to that section of the heart. And right here. So if there's blockage right here, this would be ischemia. As it progresses, you get injury. And once it's completely infarcted, it's dead tissue all the way through. Now, the muscle starts to die from the inside out because your coronary is on the outside. So they're here and they're feeding these little microorganisms, these little micro arteries coming in. And that's why with COVID and cardiac inflammation, more people are having problems, especially with rhythm changes and lack of oxygen to the blood because it's inflamed. Once it's once you have an inflamed heart, just think all those little microembolisms that are feeding the inside of the heart or feeding this muscle. Here's the main artery, but all these little things are feeding it. So as you have a heart attack, the muscle starts to die from the inside out. Once a person has a heart attack, you got to realize that part of the muscle is not coming back. It's dead tissue. Impulses won't go through there. Electricity won't go through dead tissue. That muscle is not pumping. So what does your body do? The rest of the muscle around it up here has to pump and pull and drag that dead tissue with it the rest of its life. Okay? It's not going to regenerate itself. Years ago, they thought they could transplant cardiac cells to regenerate, but they can't. They're so far away from that. So here's the thing. If you have heart attack, even nurses, because we're terrible at this, nurses, doctors, they have chest pain, your body will usually give you a warning that something's not right. So you got to get into the hospital, get an EKG, get checked right away. And people deny it. What is it? Coronary heart disease is the leading cause of death worldwide. What's the number one reason? I'll tell you, I mean, you can think about it for a sec. A lot of people say it could be diet or anything like that. No, it's high blood pressure, hypertension. People don't feel it. People refuse to take medicine. And what happens is their heart's pumping harder and harder and harder. Your heart's a muscle. It's going to get bigger and bigger and bigger. And as it gets bigger and bigger, it stretches and it loses its pump. And in that fiber, in that muscle, I'll show you the electrical circuit board that's in there. Okay, here's the heart's muscle. Here's a mechanical contraction. Intertwined in that muscle is the electrical conduction system. Okay, these blue dots represent electricity. Heart's muscle, the electrical conduction system. I can't see the muscle. I can't see the electrical conduction system, but what I can see is the electrical tracing, the EKG complex. So that's why it's so important. So anything that's going to affect the mechanical contraction is going to affect the electrical conduction system, which then in effect will change the EKG complex. Okay, so let's say everything is measured from the baseline. Our lead 2 goes from our negative right shoulder down to our left arm, our left leg. So that's following the normal axis. Trust me, axis means the summation of where the electrical activity is. We're not going to get into axis, nothing like that. We'll save that for another time. Okay, but this is normal. So remember, anything that affects that muscle, lack of oxygen, lack of blood, trauma, is going to affect that electrical system, which is going to affect the EKG complex, and vice versa. Anything that's going to affect the electrical conduction system, lack of electrolytes such as potassium, magnesium, sodium, is going to affect the mechanical contraction. So that's how those three go together. And when you have a normal sinus rhythm, you should have a positive P wave, QRS, and T waves. And okay, let's say you've got a little blockage right here in one of your coronary arteries right here. Okay, that's going to cause ischemia. Anything that affects that mechanical contraction is going to affect the electrical conduction system here. And with ischemia, your heart's still pumping, but what happens, let me move this down. Now see how it went? The muscle, my SA, my AV node, and my ventricles can depolarize, but they have problems repolarizing. It has to go up around, so you get a negative ST depression. And we'll talk more about that. But again, it changed the muscle, which changed the electric, which changed the EKG. Okay, let's look at an EKG, the parts of it. Here's the rhythm. Let's look at the PQRST. Okay, so here's a booklet I have, but let's look at the P wave. The P wave, all that is the atrium depolarizing. That's it, real quick. It's small, it's not a big muscle, so it depolarizes, okay? Now, we have this PR interval. I'm going to show that next. The PR interval, what does that mean? Electricity works a lot faster than muscle. So electricity has to slow down and let the atriums empty into the ventricles. So what it does, That PR interval, there's no electrical activity. The impulse is just hanging around the AV node. I'll do that again so you can see that. So the blood can empty into the atrium. Then the QRS, now it goes down a bundle of his and depolarizes the heart. Okay, the QT interval. You always hear the QT, especially with a lot of medications. The QT is right here, beginning of the ventricular depolarization and repolarization. So it goes from my Q to the end of my T wave. So when that gets longer and longer with medication, you're more concerned because that's in the phase 4 section where you can go into VTAC. You don't have to know about phase 1, phase 2, phase 3, phase 4. Just remember, you look at your measurements, and we'll talk about that. Now, the baseline, the ST, that's probably the most important. More people die from congestive heart, from heart attacks than anything else. Eventually, that's what's going to kill them. So ST is at the baseline. So how do we check for baseline? We use paper. You can't see much. You're covering up 50% of the complex. So you got severe depression. You wouldn't see that on a piece of paper. It's not best practice. So this is what I developed. I'm going to show you guys this in a thing, but there's always other methods. You don't have to use this product. You can use paper and pencil or calipers if you're comfortable with them. But I designed this tool, this measuring tool, because I can put the baseline on an EKG, and there's normal, and I can see there's ST deviation, ST elevation, or severe ST depression. Now, the EKG's been around for over 100 years. Now, why is it so hard for medical personnel to interpret EKGs? Because I said before, there's so many different variations, but they all meet the same criteria. And when you think about it, this was a study done, and I want you to check it out. It's a pulse trial done in 2017 by American Heart. And their study for 7 years showed that nurses in particular have significant responsibility for care of patients receiving ECG. The nurse is responsible for clinical decision-making, and evidence suggests that nurses lack knowledge and expertise related to ECG monitoring. This is a cold, hard fact. This is 2017. What have they done to help us? Nothing that I know of. I've worked with American Heart, and I said, look, guys, you got to have a basic class. You got to, and I've worked with a lot of people from American Heart, and, you know, we've worked on it, but again, they're a nonprofit, and I like to say I'm a nonprofit, but I have to make, you know, profit. That's why I sell my products. But we've had many discussions, but you can see there's nothing out there yet. So calipers, this is what kills me. Here's a set of calipers. You can see them. These calipers are 100 years old. I got them from some guy at an antique shop, and these are over 100 years old. And what do? These aren't sharp, but we've made them smaller and sharper. And think about it. You use a two-step method, counting boxes. All right, this takes way too long. In medical school, we're never taught to recap a needle. We went to a needleless system for a while. I mean, for a reason. Every time we cap 2 needles, we can stick ourselves. Another way, which should only be the backup, is paper and pencil. How would you like it if you were my patient or your spouse or loved one, and I had the EKG, and I said, well, let me get a piece of paper. And I've done it too in situations. I've used paper towels, you know, because I don't have a paper and pencil all the time. But, you know, then you got to count out everything. This is time consuming. You know, you got to go like this and measure it out. That's a backup. So that's why I developed this badge, because when I came into medical field, I thought, why are we using calipers? Because I put them in my pocket. I said, now I'm going to measure EKGs. All of a sudden, someone will go, Gary, your pants are bleeding. And I'd have white pants at the time, so you know how old nursing was. And they'd be full of blood, and I have to throw them out. And with a needle stick, think about it. We expose ourselves to MRSA, HIV, VRE, COVID, E. coli. This is a healthcare's worst nightmare. I've gotten needle sticks before, and my first thought is, oh, damn, now what happened? You know, I got them from calipers, I got them from needles, and now with the needle system, that helped a lot. But from an infection control point, when do you think someone last disinfected the needle points from a caliper? Probably not. And you can't even find them. So just looking at an EKG, you'll get good at it, but you still have to measure. Is this red dot in the upper or lower portion of a triangle? Obviously, it looks like it's in the upper portion, but would you bet someone's life on it? It's an exact center. So it's obvious we need to take our time and measure before we act. Like Chelsea said before, take your time. I know EKGs, I've done a lot of them, but still, I gotta look at it and I can't say, what's this interpretation? Let me check it out. I go through my systematic approach. And the printouts on an EKG, and they haven't got better, it said they can be wrong up to 42% of the time. Here's an example. Normal sinus rhythm with frequent premature ectopic complexes, otherwise known as EKG. That's a PVC? That's when a person coughed. I did this guy's EKG. This PVC is 74 millimeters in height. That has to be a world record. If the computer interpretation can't tell the patient cough how accurate it could be when the difference of a heart attack could be a millimeter off, do you trust it? I worked with companies that had, EKG companies, and I said, how come you guys don't put VTAC or VFib in there? Like especially VTAC. And their response was, you know darn well why we don't do that. Because the machine doesn't see the patient, you do. So you will never have an EKG, and trust me, I've worked with EKG, saying VTAC. It'll say wide complex tachycardia, it'll give you 5 choices. And we'll talk about wide complex tachycardia. But if you can't trust the machine, who can you trust? Trust yourself and your staff. You guys can do this. It's not that hard. It's just practice. Think about it. A lot of you guys went back to nursing school, had kids, getting married, getting a divorce, and you guys done it. So this isn't bad. Again, you don't have to be an expert. Always use a systematic approach. And this is what I tell people. Is the rate, you look at it, is the rate fast or slow? Is it regular? Are the QRS wide or narrow? Are QRS missing? Are there P waves? How wide is the PR interval? Is the QT less than half the RDR interval? And again, if you use a systematic approach, it doesn't matter which, like we were told, you have to look for P waves. Well, when you look at something, it's a fast rhythm, it's wide. I already knocked the first 2 off, So for me to search for P waves, whatever works for you, but use a systematic approach. And again, it'll take time, but you'll get good. The more you see, I call it repetition recognition. The more you see, the better off you're going to be, more comfortable. And most importantly, check the patient. Like I said before, anytime there's a rhythm change, even if you don't know what it is, do a visual on the patient. I know you're supposed to do vitals and all that stuff, but in the real world, we're so busy now with COVID gowning up, taking off, And so if I'm in a room and someone calls me and said, hey, your patient went into this rhythm, I'll have somebody go look at my patient, make sure they didn't go to PEA or not having chest pain, see how they're doing. If they can get vitals, they can, but I'll come back. A lot of times people go in a rhythm change, they may go in atrial fib, they don't feel it. Sometimes they do. Depends if it's fast, slow, or whatever. Depends on the person. Okay, these are some of the rhythms I'll show you. We're going to walk through. They're easier to explain because it always shows the sinus rhythm. Okay, I'm going to play this.
What is your interpretation of this EKG?
Can you hear this? I hope.
Normal sinus rhythm. Now, let's use the EKG badge to accurately and quickly confirm. Match the R to R intervals to measure the heart rate. The heart rate is consistently 75 and within the normal range of 60 to 100 beats per minute. Slide the red line over the baseline to look for ST deviation. In this instance, we see no ST deviation. Notice that all the P waves are present and upright. Now, flip the badge over and align the calibrated red boxes under the cardiac interval, starting with the PR interval. Slide the badge along the rhythm strip to make your measurement. The PR is consistently 0.16 and within the normal range of 0.12 to 0.20. Now use the calibrated red boxes to measure the QRS intervals.
This is going
The
through
QRS interval is consistently 0.08 and within the normal range of less than 0.12. Trend the badge sideways and use the calibrated red boxes to measure the QT intervals.
This is what I talked about. The
QT
interval is 0.44. The QT should be half of right here. This QT should be less than half of the R to R interval in a sinus rhythm. In a sinus tach or slow rhythm, it's going to be longer. But just look at that. When you have somebody on medication that can affect the QT, if this ending is way over here, that's not right. I mean, then you got to start looking at that. So always remember your P wave, your QRS, your T wave, and your QT, especially if they're on cardiac meds. If there's magnesium, alcoholics have a lot of this. My mind's going blank, a lot of drug overdoses. You look for the QT interval. And the only actual way to do it is a QTC on a 12 lead. But this is how you can look on a regular EKG and say, hey, his QT is greater than half the R to R interval, as long as it's between 60 and 100. If it's over 100, it's going to be closer because our waves are together. So I'll finish this up here.
Interval is consistently 0.44, which is less than half of the R to R interval. These measurements confirm the interpretation of normal sinus rhythm. Here, we have a heartbeat of 75 beats per minute. The impulse originates in the SA node, then travels downward throughout both the right and left atria. The impulse then travels through the AV node, the bundle of His, through both bundle branches and into the Purkinje fibers, where it causes ventricular depolarization. In normal sinus rhythm, the electrical impulse follows the normal conduction pathways, causing an upright P wave before each QRS. With every electrical conduction of the heart, we should have a mechanical contraction, which gives us a heartbeat. Normal sinus rhythm is considered the gold standard by which to compare all other arrhythmias.
Okay, so before I start this one, remember, sinus rhythm is the gold standard. That's what you compare it with. And that's one of these products that I developed, this pocket guide for arrhythmias. It has all of them scaled and you can flip it over. So I'm just going to go through a couple more, and then, I see the questions on the side. But this is, let me go to the next one. This is atrial fib. Remember I talked about how atrial fib is the most common dysrhythmia in the world and why you can get a stroke? This little section right here, this is about 1 minute, 45 seconds. I'll move it up. Okay.
What is your interpretation of this EKG rhythm strip?
You can obviously see it's atrial fib, but what's happening in the heart?
Atrial fibrillation. Atrial fib is multiple impulses originating in the atrium in places other than the SA node at a rate of up to 400 to 600 beats per minute. Instead of pumping, the atria begin to quiver, causing fibrillatory waves illustrated by the red arrows. These chaotic impulses make it to the AV node, but not all of them make it through. This causes an irregular heartbeat, illustrated by the blue arrows. The fibrillating atrium can cause blood clots, which can break off and lodge into an artery of the brain, causing a major stroke. With atrial fibrillation, the risk of stroke increases by 500%. Compare this to normal sinus rhythm.
And see what happens in normal sinus.
Atrial fibrillation is the most common dysrhythmia in the world.
See how it looks on the right? In the left, the atrial fib is...
You can flip the comparison strip on the bottom panel to compare this rhythm to normal sinus rhythm.
And you can compare each one like that. So that was strip 9. So let's look at, that was atrial fib, sorry. Let's go to 36. Atrial fib, you're going to have a pulse. It's going to be irregular. If it's fast, greater than 100, then it's atrial fibrillation with RVR, rapid ventricular response. Because again, it doesn't matter if this is beating at 400 or 600 times a minute. My pulse is my ventricles pumping. So if it lets 60 or 70 beats through, that's within a normal range of 60 to 100. If it's going at 150, 140, 160, then it's rapid ventricular response. So that's the difference. Atrial fib versus atrial fib with rapid ventricular response. Rapid ventricular response means it's greater than 100. So if that's atrial fib, what do you think this one is? Move it forward.
What is your interpretation of this EKG?
Pretty much ventricular fibrillation, right? There's no pulse.
Ventricular fibrillation, more commonly known as VFib. It is the most serious cardiac rhythm disorder. Just like atrial fibrillation, you have irregular and chaotic impulses, but now they are in the lower part of the heart, or the ventricles, which pump blood throughout the body. This fibrillation, or quivering of the ventricles, causes the heart to stop pumping blood altogether. With VFib, there is no pulse.
When people tell you they were in VFib and they went out of it, they did not. It was artifact. Nobody's ever going to go into VFib and come out of it by themselves. Yes, you could do a precordial thump. Years ago we did them. Never seen it work. It could, but again, with VFib, there is no pulse. And if you go around a room and say, you know, you see this, it's usually artifact if the patient's talking to you. Let me get this back. Yeah. Okay. I'm just going to move ahead. So we know that. And again, always comparing it
to normal sinus rhythm.
And again, you can always flip the comparison panel over in this booklet or anything.
You can flip the comparison strip on the bottom panel to compare this rhythm to normal sinus rhythm.
Okay, so we know the difference between atrial fib and ventricular fib. Atrial fib is going to have a pulse. It's a higher risk of stroke versus VFib, there is no pulse. And a VFib, that's why if I have atrial dysrhythmias, I can work on them. If I have junctional dysrhythmias, I can work on them. If I have ventricular rhythms, that's when I get worried because now I have no backup. SA is my primary node, AV is my backup, the ventricle is my backup. So when somebody's throwing PVCs and they go in VTAC, there's nothing beyond that except VFib and asystole. So PVCs, wide complex tachycardia, you're concerned about. And now we'll talk about what happens to your heart with ST depression. I'll move it ahead here. What is your interpretation of this EKG?
Sinus with ST depression. Let's use the EKG badge to interpret this rhythm. Align the red line of the badge with the baseline and slide it along the rhythm strip looking for ST deviation. Here, you have ST depression greater than 1 millimeter below the baseline. This depression may indicate ischemia, which is the lack of oxygenated blood to the heart muscle tissue.
There's other reasons people can have ST depression. A bad heart, people that have CHF, enlarged heart. Remember, anything that affects a muscle is going to affect the electrical conduction system. If the muscle gets bigger, it's going to stretch those fibers. That's why people with cardiomyopathy are more subject to atrial fib and even problems repolarizing as with ST depression. So again, you always consider it first, ST depression first until ischemia until proven otherwise.
This is usually caused by a narrowing of the coronary artery caused by plaque buildup. Ischemia is usually the first stage of a developing myocardial infarction. The buildup of arterial plaque begins to deprive the heart of the proper amount of oxygen, causing damage to the heart muscle tissue.
You see that little blockage right here causing ischemia? The impulse can go through, but it has trouble going through.
Go through the ventricles, causing depolarization, but has trouble repolarizing, illustrated by the impulse going around the ischemic area during repolarization. ST depression could also be the sign of a non-STEMI or reciprocal changes.
Exactly. We can talk
Compare this to normal sinus rhythm.
So
you can flip the comparison strip on the bottom panel to compare this rhythm to normal sinus rhythm.
See the difference? This is probably the best one I made because it explains an MI. You've seen ischemia. Now this is probably the most important one.
What is your interpretation of this EKG rhythm strip? Sinus with ST elevation. Slide the red line of the EKG badge on the baseline and look for ST deviation. Notice how the S wave does not come down to the baseline, and the S wave and T wave come together to form ST elevation. Here you see ST elevation greater than 1 millimeter above the baseline. This may indicate myocardial injury and is usually the second stage of a myocardial infarction. This is commonly caused by an increase of plaque buildup, narrowing the coronary artery.
So see what happens? Now the muscle starts to die from the inside out because we have more plaque buildup. So here, this person needs to get to the cath lab right away. Now, ST elevation can only be 1 millimeter high, or it can be huge, like tombstones. Obviously, the higher it is, the more risk it is for damage. But again, it could be with a two lead. Anytime you have ST elevation, or anytime someone has chest pain, get a 12 lead because you only see one view on the rhythm here. Oh, so that's, and okay, before I go any further, I can see the thing. Any questions on that? ST elevation is the most important one. You can have other reasons for ST elevation, like early repolarization. But again, anytime you have ST elevation, ST depression, let a doctor know. Should you call a doctor in the middle of the night if there's a rhythm change and the patient's not feeling right? Absolutely. If you see something, if you have vented patients and they're having episodes of VTAC, do you call a doctor? Absolutely. You cover yourself. Because remember what they said. You do that 20-question EKG test every year. That means you're confident. That you're competent in learning EKGs. And the hospital really won't back you up if somebody else wanted to see those EKGs and you signed them off and didn't call a doctor. Because think about it. After you know this stuff, you'd want somebody there. If you don't feel comfortable with it, how do you think your coworkers do? And that's what I'm saying. Work together on this. Junctional rhythm. You always hear about the word junctional rhythm. There's no P waves. This will explain it. This is the new workbook that I got, and I'm finishing up these animations. This will be available, and I'll talk about that in a sec. But junctional rhythm, what exactly happens here? There are no P waves, right? This is non-narrated right now. There are no P waves, and this, you measure, heart rate 68, so it's actual junctional tach, or accelerated junctional rhythm. P waves may be absent or inverted or following QRS. Why? Because watch, the impulse comes down, but the AV node fires, so it sends these back, it sends the atrium back again. It sends it back upward, so anything going towards a negative lead is going to be negative or buried. So right here, you can see that there's no P wave because it's probably buried in the QRS because this took off right here. I'll show it one more time. The impulse came down from the SA node, but the AV took off and it sent it back. This electricity made it go backwards. So that's why you can have it before, negative, inverted, or following a QRS. I've only seen it one time follow a QRS, but it's usually there's no QRS because it's in here I'm sorry, there's no P wave because it's either inverted or it's hidden in the QRS. And last one here I want to talk about is, I just did that one, sorry. 118. What if you have a combination of both things? What if you have more than one thing? And that's what happens. You know, we learn the basics of, okay, this is VTAC, this is Atrial Fib, but there's so many different variations. Or you can have ST elevation with a significant Q wave. So here, this one right here is, I'll let you guys figure this out. This is the non-narrated part from the book. Okay, let's use a systematic approach here. The heart rate's 60. I don't see any P waves. There's ST depression, and the QRS is normal. So here's an example. See how the impulse initiates from the SA node, the AV fires, so it sends those back. It goes through, and on the way it returns, it's depressed because it has trouble repolarizing because it has ischemia. So the junctional rhythm, again, there's no such thing as no P wave. It's there, but the junction becomes a primary pacemaker, unless you cauterize it or you had it. Usually they have an atrial pacer then. So, given that, what's your interpretation of these EKG rhythms? Okay, looking at this is a wide complex tachycardia. Both these are, right? Why is one up, one is one down? Is this a P wave here? No, and that's why it's so important. Both of these are V-tach. Now, why is one up, why is one down? It depends what area of the heart it comes from. This one could be coming from the left ventricle. This one could be coming from the right ventricle. That's why any wide complex tachycardia, consider V-tach until proven otherwise. And that's where you seek expert consultation, calling a doctor. Because so many times, here's a prime example. If we're healthy, I'm pretty healthy, I don't have any heart problems, but if I had a wide complex tachycardia, it's a 70% chance that it's V-tach for me. If I have cardiac history and I go in a wide complex tachycardia that's regular, there's a 90% chance that it's V-tach. So when people say, oh, the guy's fine, you can be fine for a while, but you can't be in V-tach forever because your heart's going to tire out. It's going to use all of its phosphates and you're going to end up asystole or V-fib. So remember, any wide complex tachycardia, just remember that it's considered V-tach until proven otherwise. So some key points to remember. You don't have to be an expert in interpreting EKGs, just know when to call one. Recognize changes. Practice, practice, practice. You have a whole slew of EKGs in the hospital with every patient. You get it, when you look at the patient's name, look at his EKGs. It's repetition recognition. Okay, that's atrial fib. That's this. I'll see it. The more I see. Realize you can't change someone's past, but you can help change your future. Biggest fear I used to get when I worked in an emergency room was, okay, I'm getting a trauma that's, thrown from the windshield, belted, unbelted, head lacerations, all this stuff, and I'll be in the trauma room, and I'd be thinking, damn, now I got to do this. Okay, I can't change what happened, but I can help change his future. Just like a lot of people are non-compliant. People come in and they have chest pain, and all of a sudden they're having chest pain, and you look, their blood pressure's sky high. You ask them what medications, they haven't taken their medications, they're on dialysis, they missed dialysis, they're short of breath, they're going to crash on you. There's not much you can do about their past. You can do your best to change the future, but don't panic. Just remember the 3 C's. This will help you so much. Remain calm. If you panic, everybody else does. Just remain calm. Remain cool. And what I mean by that is I've had many times before the COVID thing, I work in a heart unit and people would be having chest pain and I could see there's ST elevation and I would be like, family would be like, is he having a heart attack? Is he going to die? First thing you do is remain cool. Say, okay, what I'm going to do is he's having some chest pain. He has some EKG changes. He could be having a heart attack. Never tell him they are. That's a doctor's call. And say, now, it's going to get busy here. I'm going to call an RRT. I'm going to call a doctor's stat. So we're going to have a lot of people here. So I'm going to ask some of you people to wait outside here if you want one person in here because we're going to get very busy here. And when you're calm and explain that to them, it helps them a lot. It helps them trust you and trust yourself. The biggest thing is now be collective. Start thinking, okay, what do I need? Do I have IV access? Is this person, I'll talk about that. Where's the crash cart? Crash cart's out in the storage room and bring it closer to or in the room. If you have a patient that you find pulses down on the ground, you run out in the hall and yell, I need help. That's the worst thing to do. That's why they gave you phones. If you've got a guy that's pulseless, don't run out and look for help. Dial your code number. Like ours was 777. I'd say code blue, room 215. All my coworkers would be right down the hall, maybe busy with something. They go, code blue. Oh, I can stop what I'm doing. But when I get people yell out, I need help here, and run back in the room. Mistake. You got a phone. Let them call overhead. If a guy's looking bad, call an RRT. Someone will bring crash cart. The staff will come. What saves lives 90% more than CPR? Now, with CPR, you have to realize studies have shown when you start CPR on somebody, they have a 20% survival rate. And you can look this up on the Science Direct, that of those 20%, greater than 50% have some neurological damage, the survivors. They may not be able to walk, talk, toilet themselves, feed themselves, or hold an intelligent conversation. So CPR, when someone's doing CPR, the chance of them coming back neurologically intact are 7%. But it's the best we do. Think about it. You're taking your sternum and pushing it down 2 inches. I'm manually pumping your heart. What I want to do is I want to avoid CPR. I want to look at those changes. I want to look at that EKG, look at the patient, listen to his lungs, do a complete assessment, and react. Do something about it. Call the doc. Say, hey, this guy doesn't look good. Don't be afraid to say, hey, this guy doesn't look good, but hey, he doesn't look good. What's wrong with him? Don't know. I can't figure it out, but I got a bad feeling on this. You better come up here. And if you call the doctor and they brush you off, you are the patient advocate. You tell them, say, hey, look, I'm calling you for a reason. This is a concern. He's having a lot of PVCs, and at least you did your part. Unfortunately, there's some people that are very arrogant, and there's not much you're going to do about it, but get it moving. If you can't, then go through the channels. Another thing is, you want to learn EKGs, you want to learn respiratory, talk to your doctors. When you're working with staff, always remember, introduce yourself. How many people come on the floor? You're working on the floor and all of a sudden there's a new doctor, or new PA, or new NP. Go introduce yourself. Call them by their name. So then you have some connection with them. Even cleaning people. Get to know your whole staff. You all work together. There's a lot of time. I mean, I knew all our EVS people, everything else I knew by their names. I float around and knew all the docs. And I'd say, hey, we need this. Okay, I'll get this for you. This is the book that I developed, and it's 120 EKGs, and it has all those moving EKGs. It's in 6 sections, 20 sections each, and it's right here. It opens up and it has 120 EKGs, 20 of them, or 120, but it does 20, then it gives the answers. 20 gives the answers. 20 gives the answers. And it has a picture of the hearts. It has cardiac definitions and index. If you just want to focus on ST elevation, it gives you 12 different views of ST elevation, atrial fib, second degree heart block, premature ventricular attack. Remember, there's no better feel in the world knowing you did something to help change a person's life. I mean, when you catch something and you save that patient's life, that's priceless. That is like gold. You feel so much better. In our jobs, we do so much, and we don't take advantage. We don't, give ourselves enough credit. Thank you. What I wanted to talk about is this badge comes with a little booklet here. And when I met Chelsea, because I would float all over the place, and with Chelsea's stuff, this Chelsea tribe, the guru cards, I told Chelsea I retired, but I would have died to have these cards when I went to ICU, because my tool measures, but she has reference tool for ventilators, for cardiac drips. And we're all floating now because there's such a nursing shortage. So what I would have done, and I've told people to do this, keep these. If I'm working to, if I had a float to mom and baby or pediatrics, I would take the pediatrics cards and put them in my name badge and keep them there, because I don't know how many times people come and they're on a, what do you call it? Not SML, Cardine drip. And I would tell people, I've never messed with a Cardine drip. Well, they could see what Cardine is with these little cards here. So these are very nice. I got to say, the quality is excellent. And then Chelsea and I just started talking about this stuff and a couple weeks ago, about a month ago. So if you want information on my products, you can visit EKG Concepts or EKG Concepts LLC at Amazon. There's other products I have out there. The book, the pocketbook, all those videos, the 39 videos where it shows a heart, those are free. You can go to my website, EKG Concepts, and watch them. They're about 2 minutes long. There's 39 of them. And again, you don't have to buy anything, but it does follow this booklet with the badge. And If you guys have any questions, you can contact Chelsea or contact me, and I will take the questions next. And we just put the book on sale today, the EKG workbook, for 10% off. It's $36. But any questions?
I didn't see the link for the article that you mentioned from the American Heart Association. And then other than that, there was just comments, not questions.
Okay. It was the Pulse trial. Have you checked that, the Pulse trial?
Right, the post trial, the link to the post trial article, if you have that available.
Yeah, I can get that. I'm not going to jump off my computer. I'll send it to you, okay? Because I don't want to lose it.
Yeah, that's great. And other than that, I don't see any questions coming through. I really appreciate your time, Gary, and those of you that tuned in. It was great. I love the idea that, we're all capable of making such an impact. And as long as you're exposing yourself to those things that you're uncertain about, EKGs or anything else for that matter, whether that's ABGs or EKGs, I mean, there's just so many things in our realm of nursing. And if you would just expose yourself and get used to your uncomfortable areas, make that your comfortable areas by exposure and recognition. So, Gary, thank you so much for your education, your resources, your expertise. I love that. I know you don't like to call yourself an expert, but I appreciate your time.
An expert, because the experts are the EP cardiologists. You know, look at all the EKGs, But yeah, if you guys got any questions, contact Chelsea. Chelsea, if you want any more classes, I'd be happy to do these for you. If you want a 12-week one or whatever, just let me know.
Awesome, great.
A little more, start right into it right away.
What's that? I'm sorry.
I'm saying, next time if we do a class, we can go right into it and go right, add more stuff to it.
Sounds great. That sounds perfect. Guys, I just want to say thank you for being the tribe, empowering each other, learning together, laughing together, and supporting one another. Never stop learning. Have a great day.
And thank you, everybody.
See ya.
See ya.